Commissioner, Chair, colleagues, I'm delighted to be here, and I would like to thank the Irish Nurses and Midwives organisation for inviting me to speak at this summit. I don't know if I can follow Marion in quite the way she's able to explain herself. You're quite wonderful, Marion. I hope I learn a lot. I'm new to being an MEP, but I'm not new to putting the case forward. As a senator, I was a member of the Joint Oireachtas Committee on Health and Children, and we had an opportunity on a quarterly basis to meet with the Minister for Health and the team from the department, and also to get parliamentary questions answered and to put forward issues that were of very great importance. So I would see that there will be a role in that department as well, where the case can be progressed further. I would want to congratulate all those who lobbied so effectively for the Sharps Directive to be introduced. And because of that work, we're not here today talking about what needs to be done, but indeed talking about how we should do it. And that's a welcome change, and it's a very necessary change indeed. I want to talk about the challenges that face all EU member states in implementing the Sharps Directive and how we in Ireland are going to be implementing it, because having an EU directive in place does not guarantee its proper and timely implementation at national level. We have seen throughout the EU in other policy areas, and we're no angels, we've seen that throughout the EU, and we're no angels in Ireland. In fact, when I was going forward as an MEP, one of the briefings, the many briefings, it was said to me that we in Ireland have a habit of implementing policies to the nth degree, so we always were top of the class, and sometimes that kind of stymied us as well, because there was a limit if we put in too many restrictions. However, I'm sure it'll get easier in time to kind of understand that. I'm confident that we in Ireland will put in place a comprehensive suite of measures that will give full effect to the directive by the implementation date of May 2013. I'll go through some of the efforts that are already underway. Those of you who will have heard Blonid this morning from Beaumont will have got a flavour of what's going on here already. I think it's worth remembering why member states take differing approaches to implementation, and I note that Spain took this under the health and safety legislation and were way ahead of the posse in implementing this very good plan, so they already are a country that has quite a degree of success, and I'd like to acknowledge that. The main reason the European Union places a great deal of emphasis on subsidiarity, and that's the principle by which member states actually implement EU rules in a way that kind of best suits their own needs. It's a very important principle. In this country, we have a new government setting out on a new path for our health system that recognises the weaknesses of one-size-fits-all policy. Healthcare settings they're not like fast food outlets where you can have one in every country and it's the same recipe, and that seems to work if it's McDonald's, but it doesn't work for everything, as you can see. The particular strength of EU directives is that they can be framed within a national context. This can have a complicating effect for the development of implementation strategies, and I'm sure that that's no stranger to us here that would make policy decisions. And indeed, having worked as a midwife for over 20 years down in South Tipperary General Hospital, I was on a few occasions at the wrong end of a needle. Not anything like the harrowing testimonials that I read in preparation for today, where somebody with an obvious diagnosis that is with HIV, not having had to go through that. But on a couple of occasions I did have a needlestick injury where I didn't know the status of the patient because of the nature of their presentation to the hospital, and it is such a worrying time, and I don't think anybody can underestimate what that feels like. But for whatever it might be like for us as healthcare professionals, it has to be worse for people that are not healthcare professionals but work within the system, such as care workers or cleaners or whatever, and sometimes in the laundry services, where they would come by a needlestick injury without knowing the full process of what's involved in it, and that can't be underestimated. And the Commissioner mentioned here about 1 million instances in a year. That's a lot of worry, that's a lot of blood tests, that's a lot of waiting around, wondering what's your prognosis, what's the outcome, what's the blood, what's the status, are you going to get something, and is the worry going to be ongoing, can you continue to do your job? It's very harrowing, and to read those testimonials, it's particularly harrowing when you kind of have been through that, but in a lesser way, because certainly, you know, when we know our status, and especially in midwifery, because for the most cases anyway, the patients are well, you know, their status is well established by the time they come to have their babies in the labour ward. But anyway, that's a challenge that, you know, can be overcome by sharing knowledge and experiences. In relation to the Sharps Directive, this summit provides that opportunity, and the European Biosafety Network ensures that the process will be ongoing. Work still needs to be done with the health services across the EU, but that work will be worth it, because the ultimate aim is to maximise the effectiveness of the directive for everyone, no matter where they live. And I think that's something that we would all, you know, agree with. The process that led to this directive is a guide as to how things can be done at national level, because when drafting the directive, the European Commission incorporated the views of both employers and employees through their representative organisations. The directive provides for such a process to take place in member states, so delegates can take encouragement from there being one successful model to follow in implementing the directive at member state level. And there are other ways of doing it as well. We have certain structures in place and certain experiences in Ireland which could be disregarded in the principle of subsidiarity did not exist. If we were simply told by the European Commission to do it in a particular way and no other way, then the directive could have less effect on an EU-wide basis, because there could be little regard given to local circumstances. And I think we have to remember that, especially in this country, where our health services and various pockets where we don't have centres of excellence, but where we have a very good service, that we shouldn't have a rule that's because one size again doesn't fit all, as I said earlier. We're approaching the directive from the point of view of employee safety, and this is how we developed our highly regarded smoking ban, which is workplace safety legislation, and everybody can attest to the success of that. The lead agency in implementing the directive will be the Health and Safety Authority, which is under the Department of Enterprise, Trade and Innovation. They will draft regulations based on the directive and prepare a regulatory impact analysis by early 2012. Assuming all is well, then the draft regulation will be put out to public consultation, which will give the stakeholders an opportunity to have an input. A finalised draft will then be prepared with accompanying regulatory impact analysis for the Minister to put before our Parliament. Naturally, there will be significant inputs from the health agencies throughout, I have no doubt about that, and work has already been underway for some years. Within the Health Service Executive, which is our lead health service agency, a bloodborne viruses group has been up and running under the chairmanship of Dr. Kevin Kelleher. It has already made a number of recommendations in relation to Sharps injuries, with an emphasis on prevention strategies and the use of safety engineered devices. Injury awareness is also part of our informational process for healthcare professionals, and in the Health and Information Quality Authority, we already have an agency that can monitor the implementation of the directive once it is transposed. The Sharps Directive, therefore, is building on work that is already taking place. But it serves another purpose as well. It will create a set of universal practices for all healthcare settings in Ireland, including risk and assessment and risk prevention, training, information and awareness raising, assessment and monitoring, and response and follow-up. And it could also allow us to achieve economies of scale through centralised procurement of safety engineered devices. So while the directive presents challenges, they can clearly be overcome, and that will mean a safer working environment for people who are every bit as entitled to a safe healthcare environment as the people that they're treating.